Hello, everybody. Welcome back to the Doc Talk podcast, real talk about real healthcare from two doctors who've seen a lot and are here to help you navigate it all. I'm Dr. Shazma Mithani, an ER doctor.
And I'm Dr. Sheila Wijayasinghe, a family doctor. So I'm really excited about today's topic, Shaz, and I think it's one that we've kind of alluded to a little bit on different episodes, but one that really strikes a lot of people out in their hearts because I think we're all affected by this in some way or another. So today, our question today that we want to dive into is inspired by a listener. So let's take a listen to this one.
Hi, docs. Here's my question for you. I've been hearing that cancer rates are on the rise. I'm wondering if there's anything you can suggest that I do to prevent this or reduce my risk. Thanks.
This is such a great question and one that I get in my office a lot. And Shaz, I imagine you see people at the other side of this where we're not preventing it, you're treating cancer and the end stage effects of that. So I'm really glad that we're addressing this because, you know, we're going to talk about screening and how to screen and why cancer screening is really important and catching something before it causes symptoms because early detection can save a life.
Absolutely. And, you know, as you mentioned, Sheila, I see this in the ER when it's too late. So when people are coming to the ER, by the time they're coming to me, they likely have symptoms from whatever the cancer is. And at that point, it's usually a bit more advanced because it's already causing symptoms. And that can certainly affect things like the ability for us to treat it, the survival rate, the morbidity associated with it as well, which is why screening is so important. And a lot of times it's because when I see these people, it's because screening hasn't been done or it's been missed or people aren't even aware that screening is an option for a particular type of cancer. And as you mentioned, screening can save lives and it's often picking up these cancers before they're even symptomatic. That's kind of the whole idea, right? It's picking cancers up in kind of the precancerous stage or very early stage where it's still very treatable. So we're going to do a bit of a different style of episode today. It's going to be very rapid fire. We're going to talk about several different types of cancers and the screening related to them. And then we stick around for the end because we are going to have a fun little true false back and forth between Sheila and I. Let's dive right in.
So I think I love that, Shaz. And I think when we talk about screening and what you just said is really important. Screening is different than diagnosis. So screening isn't about symptoms. It's actually when you don't feel anything. And that's why people don't get screened is because often you come to the doctor, you associate coming to your doctor's office to when you're having symptoms of some sort. So your stomach hurts or you're feeling like you've had unexplained weight loss or there's blood in the stool. Those are the reasons people come in, but that's not screening anymore. So screening is really for checking for something prior to you actually develop anything versus diagnosis is if you have symptoms and that's not screening anymore. So when we talk about this is really important because again, like you said, we can catch things early. And again, this is why when you see things in the ER, it's sometimes too late or it's more difficult to treat.
Yeah, I think you bring up a really good point there about how I think there's this general approach to seeing the doctor is I go to the doctor when I have something wrong, but every patient of every age, even my kids see their doctor every year for like an annual health check, right? To make sure all their numbers are looking okay, to make sure there's nothing that's coming up in the physical exam or even in the history, like from a mental health standpoint, from a physical health standpoint, the same thing with me. I mean, I see my family doctor every year and I check in with her to get a sense of, what screening should I be getting right now? Is there anything that I'm now aging into? And then again, just doing like a check-in to make sure everything's going okay and there's no additional testing or referrals or anything that needs to be done. And that is during a healthy state where I'm not having symptoms. Yeah. Of course, then between those, annual exams, if anything does come up, I go and see my family doctor as well. But I think you bring up a really good point here is that we don't always just see our doctors for symptoms. Screening is such an important part of preventative health to make sure that we're not getting sick and kind of catching things early. And then, like you mentioned, not ending up in the ER when the symptoms are there. And then it's often too late to treat in an effective way as we could.
Yeah, I love that you bring your kids in because I think that creates the discussion and it becomes internalized for them. I see my doctor when I'm well as well.
Exactly.
And that's tricky. The healthcare system is very strained right now. And so to think about going in when you're well to do these things, I have to tell you, this saves money for the healthcare system in the long run. It saves lives in the long run. we know that this is really important. It's a very proactive approach to care. And sometimes people are afraid to get screening done because they worry that we're going to catch something. But when we screen when you don't have symptoms, we are much more likely to be able to treat and cure something rather than waiting till those symptoms develop. So
it's good that you mentioned that, because like the first topic we're going to go into is breast care screening. I actually just had my annual mammogram and ultrasound this morning.
Oh.
I'm so glad that I like every time it's time to have it done, I actually feel nervous. I'm like, well, what if something gets found?
Mm-hmm.
And then you know what? I remind myself that if something does get found, it is caught early and the chances of it being treated effectively are much, much, much higher. And so, yes, I mean, I want to like validate for our listeners, there are nerves around it. It is normal to feel anxious about it and to almost feel like you want to avoid that screening because you're worried about what it will find. But the way that I kind of try to always approach it is, well, you know, the something that's there to be found is going to be there anyway. You're better off finding it earlier, and kind of leaning into those nerves in that way. And so let's dig into breast cancer screening since we're on that topic right now.
Perfect. Yeah, absolutely. So thank you for sharing that. I think was the mammogram really uncomfortable? Were you okay? Like
So it's my second mammogram. So I kind of already knew what to expect, right? So I'm now 41. I started at 40 in consultation with my doctor because the age can be different. And so it was my second mammogram. So I had an idea of what to expect. It's like mildly uncomfortable. They like for the mammogram, the breasts are being compressed between kind of two plastic plates with like quite a bit of pressure.
Yeah.
But it's quick. And then I had an ultrasound as well, an automated breast ultrasound as well, because I have dense breasts. So again, like there was some like pressure. I wouldn't even say it was like painful or uncomfortable. It's just like, it's a bit awkward, but it was so quick for both of them.
Yeah. I tell my patients the same thing. When we talk about breast cancer screening, the tool is mammograms, and sometimes you need the supplemental ultrasound as well, like you mentioned, Shaz. When I've had my mammograms, I sort of brace myself for the discomfort. But to be honest, and I do have many patients who say they don't want to get a mammogram because they've heard it's uncomfortable. That's why I ask that question, because it is a short sort of about 8 to 10 seconds of squish, and then you go to the next side. And so then I tell my patients to count down, let their technician know that they may be uncomfortable. They do what they can to make it as comfortable as possible. So when we talk about breast cancer screening specifically, the Canadian Task Force, which is sort of our overarching guideline creator around preventative care, suggests that we do screening mammograms every 2 years for individuals aged 50 to 74 who are of average risk. So they're not at elevated risk because of family history or otherwise. But this is a really big conversation and somewhat controversial because there has been a lot of discussion around the age that we start breast screening, because the recommendation from many different societies, including in the US, Preventative Care Task Force, so our counterpart in the US, is actually they start screening at 40, and they recommend starting at 40, specifically because of equity and the potential for earlier detection. And when I say equity, it's because we know that racialized individuals, so Black, Asian, and Indigenous women are diagnosed with breast cancer earlier when they're screened earlier. And that makes a big difference for outcomes. And many of us, including myself, are actually advocating, and yourself too, Shaz, I'm sure, we're trying to advocate to say, listen, like we need to reevaluate these guidelines to make sure that we're reaching everybody who really does need to be screened. So for this reason, many provinces have actually shifted to allow for screening at age 40 by self-referral. So you don't need a referral from a physician or a nurse practitioner, and you can self-refer at age 40, which we can put in the show notes what those provinces are and territories are, because then you can go proactively yourself if you don't have a doctor or a nurse practitioner, and you can do this yourself as well.
Yeah. And I think that shift is such an important thing to bring up. And my hope is that like the Canadian Task Force, like we've already seen that they're edging closer, right? They've gone from 50 to 45, and hopefully now sooner rather than later, they'll go from 45 to 40. And, in the Emerge, I have seen younger and younger people who are diagnosed with breast cancer who come in with advanced disease and like didn't meet that age threshold for screening. I certainly have had, I know friends who are kind of under the age of 50 and 45 that have been diagnosed with breast cancer and thankfully caught early enough that the treatment has been quite successful. And then, as you mentioned, there is a very important equity piece to this because there are racialized populations, in particular Black, Asian, and even Indigenous women who are at higher risk of getting diagnosed younger. And so I think it's important to, I mentioned that I'm 41. I started getting screening at 40. It is still, even if you're in a province that doesn't start until the age of 45, you can still have a conversation with your family doctor to talk about the risks and benefits to starting screening earlier. And like the biggest risk is false positives, and then the anxiety and the additional screening and testing that has to go along with that. But it's a risk that as long as you're willing to accept it, then it's an important conversation to have with your family doctor. I mean, we know that 1 in 8 Canadian women in their lifetime at any point are going to develop breast cancer. And like that's an important number to keep in mind when we're thinking about screening and that preventative health, like you said, because preventative health is very much worth its weight in gold, right? It saves money, it saves lives, it saves morbidity and anxiety.
Yeah. And the guidelines were supposed to change to 45 and they didn't. They're still at 50. And so that's where we're hoping that change happens. They actually paused and now they're reevaluating it. So this is hopefully, fingers crossed, this does change.
And we have seen a lot of provinces, even despite those guidelines, move to 45
100%.
In terms of their starting age,
and
which
40.
is great.
In Ontario, it's 40 now. So I really appreciate that because I think it makes a big difference. And I love when my patients are like, and we have a conversation, like you said, Shaz, like anytime you're doing screening, it's important to have that conversation of, if we do find something, this is what the next steps would be. So my patients have a clear understanding that we only screen for things that we have something that we can do for what we're screening for. And that's an important consideration as well, because there are treatments available. The key thing also that I always want to mention here is that if you have a family history or you are part of a higher risk group, so if you carry something called the BRCA1 or 2 gene, you need to talk to your healthcare provider about possible early screening. So if many members of your family have breast cancer, or sometimes there's a complex of cancers in your family that come together, so colorectal cancer, breast cancer, lung cancer, if there's a constellation of people in your family who have that, it's important to talk to them because you don't fall under average risk anymore for this routine screening. You may need to start screening early. So, for example, I have patients who are 30 and we screen them at 30 because of their family history. And that's a thorough discussion that we have and make that decision together. The interesting thing is, though, most women diagnosed with breast cancer have no family history. And so this is why—
Which really highlights the importance of screening, right?
Exactly. Average age, 40 to 45 is where we're suggesting.
Perfect. Okay.
Get into, go ahead.
Yes. Let's move right into cervical cancer because I want to make sure that we get to everything.
So cervical cancer is one of the most preventable cancers that we know. In Ontario and most provinces across the country, we start Pap testing at age 25 and we repeat that test every 3 years if the results are normal. What's interesting and super exciting, we've been waiting for this for a long time, is that now HPV testing, which is the virus that causes changes in the cervix that over time will lead to cervical cancer. HPV testing previously wasn't covered, but it is now replacing Pap testing in many provinces. And again, we can put this in the show notes. It is a much more accurate test. It picks up the presence of the virus. And if it's
is it still like a cervical swab that's
still
done?
A cervical swab.
Okay.
So in BC, it's actually self-swab, which is wonderful because getting a speculum exam is not comfortable for everyone depending on your own personal health history, or if it's uncomfortable in the past, you may not want to get a speculum. Again, it goes to why people don't get screened because of discomfort potentially. And so self-screening is in BC. We're hoping that it comes into Ontario. I think that will be the trend in the next few years. But right now, it's still like getting a regular Pap test, so the speculum exam, and then we collect just a sampling of the liquid to see if the HPV is there. And the good news about HPV, so Pap tests are every 3 years in the provinces that are still doing the Pap test. HPV test, because of how accurate it is, we do it every 5 years. And so this is really important. We start at age 25, similar to a Pap test. We continue till about age 70.
Awesome. And, I think that's it's important to understand like how linked HPV is to cervical cancer. So 90% of cervical cancers are caused by HPV. And it's such a common virus. 8 out of 10 people get it in their life at some point. And so from an ER perspective, this is, like you said, it's one of the most preventable cancers. Cervical cancer is one of the most preventable cancers. And for me, what I see often is when people are not screening, not knowing that they should screen, they'll often come in with abnormal uterine bleeding or vaginal bleeding or pelvic pain because they haven't been screened. And then either when I, do a pelvic exam on them to visualize to see where that bleeding is coming from, I might see a cervical lesion, or if they end up getting an ultrasound, there can be some evidence of that on the ultrasound as well. And so it just really drives home the importance of prevention and having that primary care connection for sure.
For sure. And I think what really highlights things to me sometimes when it comes to cervical cancer is that internationally, so globally, cervical cancer is still a leading cause of death. And this is something that we don't see as much in Canada. We have about 400 deaths a year in Canada, which is, again, too many given that we have this tool to screen. But this is what the importance of screening is that globally, we know that this is still a huge issue. It's still an issue for families and everyone here who's affected by those 400 individuals every year. We can decrease this by getting this regular testing done. Let's chat a little bit about something that we talked about already, but I think it's important to highlight again. Let's talk about colon cancer, because we know that it's rising in young people. It is the second leading cause of cancer-related death in Canada, and it is highly treatable when it's caught early. So Shaz, we talked about this a bit before. We have in one of our previous episodes.
Yes. So in episode 3 of the Doc Talk, so if you want more detail on this, please go and check out episode 3, because we do go into a lot more detail about colorectal cancer and screening. But Sheila, why don't you tell us from a primary care perspective, just the summary of like what screening options are available?
So there's the 2 different screening options available at this time. We have the FIT test, which is the non-invasive type of testing where you get a kit at home, you collect a sample of stool, and it's because we don't see blood in the stool, but it's microscopically there may be some blood, which can be a sign of early cancer, or polyps, which can be precancerous. And that test starts in some provinces at 45, some provinces at 50, and we do that test every 2 years. If it's positive, meaning that they do detect some blood, the next step is to have a colonoscopy. Now, for some people, they prefer to do colonoscopy directly, which is a more invasive test in that you have a scope or a tube with a camera on the end of it that looks inside directly. And the good news about that one is if they do see polyps, which can be precancerous, it can actually be a treatment at the same time where they remove the polyps. So for some of my patients, they're like, I want to do the FIT test. It's at home. I do it every 2 years. They're at average risk. They don't feel it. They're not concerned about it. I'm not concerned about it. That's a great test to do. For my patients who may have a risk in terms of family history, we tend to automatically then go to colonoscopy.
And for those who are like not an increased risk, you can kind of opt between doing the more non-invasive FIT test or the colonoscopy. So an interesting fact about the FIT test, so it can actually catch colorectal cancer years before any symptoms show. It's great that it's done at home. There's no prep in a colonoscopy. There's no clinic visit. And certainly from an ER perspective, I mean, I often see patients with they're coming in with like low hemoglobin or anemia. They might notice some blood in the stool. They might have some unexplained weight loss. And again, kind of like we've been talking about, by the time there are symptoms, it typically means advanced disease. And so these are patients, or I might see, an incidental finding on a CT scan because they're coming with abdominal pain or bloating or something. And so when I see those things, I wonder, like, could this be a missed colorectal cancer? And, could this have been something that was prevented by screening? So as I mentioned, if you want to hear more about colorectal cancer and screening, please make sure to check out episode 3 of the Doc Talk, because we go into a lot more detail about it there.
Thanks, Chaz. Let's talk about prostate cancer. So this is a bit trickier. The Canadian Task Force actually recommends against routine blood work for a test called PSA, which is prostate-specific antigen. And this is a blood test that detects when the prostate is inflamed or enlarged or has cancer in it. And it's actually, the task force has recommended against doing this routine test for asymptomatic individuals. But many patients will ask for this test. So what we do in the office is we talk about it. I go through risks and the benefits of screening. And specifically, it's a very deep dive into your family history to understand if there's a family history of prostate cancer. Also, ethnic background, racial background, if you're of Black Canadian background, it actually you're at increased risk potentially for prostate cancer. For folks who have a family history of prostate cancer or your Black ancestry, we do actually do this test. And we talk about the intervals. It's a very nuanced discussion because, again, the Canadian Task Force doesn't give us specific guidelines around this, but we do this specifically with a conversation, and we go through why we would do this test or why we don't. The reason why we don't routinely do this for asymptomatic individuals is that number, that PSA test, can be elevated for a number of different reasons, and we don't want to, one, scare individuals, but it also can lead to over-testing and prostate biopsies and other things that may actually cause more harm. And that's why it's a nuanced discussion to have with your healthcare provider.
What about rectal exams? Are those still used for screening for prostate cancer?
Yeah, great question. It is not recommended either. Okay. And so this is something that I do rectal examinations for my patients who have symptoms. And again, it goes back to if you are symptomatic. So if you're having, and let's talk about what those symptoms might be, urinary frequency, incomplete emptying. So you go to the washroom, you don't feel like you've emptied completely. You're dribbling instead of having a good steady flow of urine. That might mean that the prostate is enlarged. Also pain in the area. Those are the reasons why we actually do something called your digital rectal examination, where we wear a glove with a gloved hand. We're checking the prostate to look for pain, to feel for any bumps or lumps or enlargement. But for an asymptomatic individual, it's not something that we routinely recommend doing.
Okay. And so, we know that the stats are, again, quite high when it comes to prostate cancer. 1 in 9 men in Canada will be diagnosed with prostate cancer in their lifetime. So some prostate cancers actually can grow quite slowly. So it's an important thing to kind of keep in mind, and may never cause harm. Like patients may have a very slow growing prostate cancer and they end up dying from something else, which is why it's important to, when we talk about things like PSA or DRE is not for screening, but for investigation if there are symptoms. It's, screening is not a one size fits all, whether it's for prostate cancer or for any other kind of cancer screening. As you mentioned, from the ER perspectives, what I often will see for patients that present with prostate cancer or end up getting diagnosed with a prostate mass is urinary symptoms, often urinary retention. So what that means is that they can't pee properly, or they're getting up a lot to go in the middle of the night because they're not emptying completely. And so then they have to get up more frequently to go. If it's a prostate cancer that has kind of spread, they can often present with back pain because prostate cancer can spread to the bone kind of preferentially. And these are often patients that either don't have a family doctor or aren't aware of what options there are from a screening standpoint. Okay. So let's move into lung cancer. Lung cancer is often diagnosed late, unfortunately, and it is one of the leading causes of cancer deaths in Canada. Tell us about what patients who might be at increased risk for lung cancer can do from a screening standpoint. Are there screening options available? Yeah, and I'm really glad that we're including this because I don't think this is common knowledge. And so we certainly always talk. I learned, I didn't know about this before we were kind of talking about this episode either. Yeah, and it's something that even as family doctors, I don't know if all family doctors do this, and it's something really important. So I hope this is a big one for people to take home if you know anybody who may be at higher risk. And so breast cancer, colorectal cancer, we talk about that all the time, and cervical cancer. We have screening programs that provinces often will send letters to patients to say, get your screening done. Lung cancer doesn't have that kind of program. So it's really upon the healthcare provider and our patients to sort of have that discussion specifically. So there is a screening program for individuals aged 55 to 74. If you have something called a 30-pack year smoking history. So if you smoked about a pack a day for 30 years or around that, and if you currently smoke or you quit in the last 15 years, although you can still get it even if it was prior to 15 years ago, you qualify for something called a low-dose CT scan. So it is a test that you get screened for. It takes a picture of the lungs. It is a better test than a chest x-ray. And we refer you for this. It's low dose. So in terms of radiation risk, it's lower dose. And this will look for any changes that can happen secondary to smoking history of nodules or early cancer. Again, this is for asymptomatic individuals. If you're somebody who has a smoking history and you're coughing, you're having difficulty breathing, or you're coughing up any blood, that is a different test route that you go. But specifically for asymptomatic individuals with a smoking history of about 30 years of smoking about a pack a day, I do it for even my patients who are half a pack a day smokers because I want to make sure that we're not missing it. But that specifically, you can get referred for a CT scan. Yeah, and I think it's important, as you mentioned, that CT scans are much better than chest X-rays. So from an ER perspective, I can't even tell you the number of times where I've had someone come in, I'm doing a chest X-ray on them because they're coming in with respiratory symptoms or worried about a pneumonia or something, and their chest X-ray is okay. For whatever reason, I'm still worried about them. Maybe I want to rule out a blood clot, and I get a CT scan, and there's a nodule that's picked up on the CT scan that has not been picked up on the chest X-ray. And so it's important to make sure that our listeners understand that there is a difference between types of imaging and a difference between screening tests or pictures that are getting taken. So before we kind of get into our little true or false break, I think it is important for the listeners to understand that, like, there are so many cancers that can be screened for, but there are also cancers that we don't have screening for yet, right? Like, things change and evolve in medicine. But things like ovarian cancer, thyroid cancer, head and neck cancers, these are things that don't necessarily have screening for them. And because there isn't a screening test, it is really important to know your body, to make sure that you're aware of what's normal, what's not normal for you, and then see your doctor, when you're concerned about something. Another good example is skin cancer. And so that's something where knowing your body is so important, right? So if there's a mole that's new that you haven't seen before, that's important to get checked out by your family doctor to see if it's something that may require a biopsy. And so that's like, those are things that then when there are symptoms or something that's abnormal, you get a test to diagnose it, because we don't have a test to screen things before the appearance of the lesion or before there are any symptoms that are there.
For sure. So this is where, as a family doctor, I work with my patients around, what is your family history? Do you have an ovarian cancer history? Again, not all ovarian cancers are genetic, but it helps to alert me. Maybe we need to keep an eye out for this. Do you have a thyroid cancer history? Do you have a skin cancer history? There is correlation in skin cancer and family history. So knowing your risk can help us also help you and keep an eye on those moles that might be changing, or if you notice a change in your body at all. And so we don't have routine screening, like you said, Shaz, but just important to know your family history, know your risks.
Absolutely. Okay, so let's shift gears a little bit. Let's do a little rapid fire true and false round. We haven't done this before. If
I know,
it works out well, I think we should do it again.
Yeah.
Like it's kind of an interesting little change up. Yeah. So let's get into it. So I'm going to go first.
Okay.
And I'll pose a true or false question to you. Okay. So Sheila, true or false? Only women need to worry about breast cancer.
So false. So men and trans folks can get it too. About 240 Canadian men get diagnosed every year with breast cancer. So it is not something that only women need to worry about. If you do notice any lumps or bumps or any changes, any nipple discharge, it's important to get checked out, because again, these cancers actually tend to be more aggressive and we need to intervene more quickly. So I'll do your next one. So true or false? If your Pap test is normal, you do not need to go back for another 5 years.
So that's a trick question. Nice try. So Pap tests are done every 3 years, not every 5 years, but HPV testing in provinces that are using it and where it is eligible, those are the ones that are done every 5 years.
Okay, you got it.
All right, next question. So true or false? If you feel fine, you don't need colorectal cancer screening.
So we've really hammered this one home, I think. It's false. So symptoms often don't appear until the cancer is advanced. And this is the whole reason why we suggest to get screened when you're asymptomatic of average risk. It catches blood. We're talking about colorectal cancer screening, it catches blood before you can see it. So true or false? PSA testing is recommended which is prostate cancer testing. PSA testing is recommended for all men over the age of 50.
That one's false. So in Canada, PSA is not recommended for routine screening unless there's, a certain population group that is higher risk, or, there's a conversation that's had with your family doctor about risks versus benefits of PSA screening. Okay. True or false? Lung cancer screening is done with chest X-rays.
And false. So we use low-dose CT scans and only for high-risk groups. So the 30-year PAC-year history of smoking is the key factor there. And so CT scans over chest X-rays. So,
love it.
I think what the key take-home messages from today are that it's really important to see your primary care doc, or if you don't have a family doctor, walk-in clinics can also order these tests as well for you. This is possible. And a lot of Canadians don't have family doctors, to start sort of reviewing what your screening plan should be. So I hope people can take from today, review your family history, know what your risks are. Even if you feel well, That is the whole point of screening, to catch things early.
And if you do have symptoms like unexplained pain or bleeding, weight loss, fatigue, anything that like we said, right, know your body. If there's something that isn't right, either visually or from a feeling standpoint, it's really important not to ignore those symptoms and go to your doctor. If it feels urgent or you can't get in quickly, come to the ER. We're here for you. We can kind of help figure out what's going on, rule out any sort of life-threatening things, and get any sort of follow-up you need as well.
And so to wrap up today, our prescription for you is to think about what you can do today. So know your age and eligibility for different screening tests for the different cancers. Know your family history, because that will also influence when we will do these tests. Don't skip out on those tests because you feel fine or you're nervous. We can help you through that discomfort as well, because really it can be life-saving. And when life gets busy, we know that life is busy. When you're feeling well, the last thing you think about is going to see your doctor or nurse practitioner. But we can get back on track, get you screened and up to date. It's not every year that we do these tests. So please do make that appointment today.
And please don't feel bad if you have fallen behind. Life, we know, I mean, we're two doctors and moms. We know that life happens. We're just glad that you're here with us listening, getting informed, and hopefully something from today's episode has either informed you or prompted you to get some screening for either yourself or a family member.
And please share this episode with someone you care about, because it could save a life.
Thank you so much to everybody for tuning into the Doc Talk today. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your own personal health needs. Please be sure to follow us on social media at the Doc Talk Pod and send us your questions so that we can answer anything you have in upcoming episodes.
And this episode is brought to you by Always Discreet. Our patients often share that if they sneeze or laugh or too hard, or even during a workout, there can be some bladder leakage. There is no shame in this, and there are solutions. You are not alone, and there's no need to worry. Always Discreet is here for you. Many women experience urinary incontinence as they go through perimenopause and menopause. Nearly half of us may encounter leaks or accidents during this time. And by age 65, about 75% of women report experiencing some form of urine leakage. Yet it's a topic we rarely discuss.
Always Discreet's Rapid Dry Core locks away even the biggest leaks with no wetness, no odor, and no visible lines, allowing you to stay active and confident. They stay in place comfortably and remain invisible under clothing. Check out the link in the description for an Always Discreet coupon and step confidently into this new chapter. Always Discreet, your dependable solution for bladder leaks.